Hello, good evening, everyone, and welcome to the EUROGEN webinar series. I'm Michelle Batty, and I'm the manager of ERN EUROGEN. That's the European Reference Network for urorectogenital diseases and complex conditions that all require highly specialised surgery. So really where the expertise is rare. And we cover paediatric, adult and rare cancers. And we're currently 56 healthcare providers in 20 member states. And across the whole ERN system, because there are 24 ERNs, all created and funded by the European Commission, we comprise 1,600 medical units in about 400 highly specialised healthcare providers. So what are we aiming to do? Well, really our aim is to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment and care for patients with rare urorectogenital diseases and complex conditions. So some of our activities, well, we do educational activities like this webinar. We also are contributing to a colorectal surgical training course very soon, so please have a look for details about that on our webinar. And we also do virtual cross-border consultations using a secure IT platform called the Clinical Patient Management System. Now, this has recently been updated by the European Commission and by IBM, and we're also able to use it on your mobile phone in an app version. It's fairly easy to use. In about half an hour, we can take you through how to upload a medical case, and then we would be delighted to have a virtual case discussion with you. And this can be very educational for trainees as well. We can connect several experts in different hospitals all across Europe to talk about a particular tricky case. So I do encourage you, please do get in touch. We'd be really pleased to help. And we have a patient registry. As you all know, data is fragmented, scattered all over Europe, and it's one of the main difficulties when doing research for patients with rare diseases. So we hope that over time, the registry will really help to plug that knowledge gap. We also work on clinical guidelines, and we've written this fantastic book, Rare and Complex Urology, with all the experts contributing. So that would be a very nice thing for you to have in your departments. It's published by Elsevier. So tonight's topic, it's interstitial cystitis, multidisciplinary management of complex BPS. And if you're interested in this topic, I imagine that you'll be at the ESIC conference this weekend in Milan. I'll also be there, so if anybody has any questions or wants to have a discussion, I'm giving a talk on Saturday, so please feel free to come and find me and ask me anything you would like. Our speaker here this evening, we're really delighted to have with us Dr. Lisa Moris, and she's a urologist at the University Hospital in Leuven, Belgium. And her research interests are ketamine-induced uropathy, bladder pain syndrome, neuro-urology, and urinary incontinence. And we know that interstitial cystitis is such a challenging condition for both patients and healthcare professionals due to its very complex and multifactorial nature. So in this webinar, we'll have a concise introduction to it and explore the current understanding of its etiology and pathophysiology. So it's eligible also for EACME accreditation if you fill in the survey that you receive after the webinar within 2 weeks and you attend live. That's it from me. Please don't hesitate to get in touch with us. All of your questions are welcome. And I now hand over to Lisa. And thank you very much, Lisa, for sharing your experience with us this evening.
So good evening, everybody. Thank you, Miss Michelle, for the lovely introduction. Good evening. Welcome to this webinar on the multidisciplinary management of complex bladder pain syndrome. For this presentation, I have no conflicts of interest. So what am I going to talk with you about tonight? First of all, I would like to start with a discussion on what's in a name. What is bladder pain syndrome? With an heterogeneous definition come heterogeneous populations. I'll dive into the search for a good definition and a search for good phenotyping of this complex disease. In the next part, I will give you or hand you some ingredients that seems to be successful in your daily clinical practice that can be discussed with your patients. And finally, combine these ingredients into what I like to call recipes for a more holistic approach to get a more individualized and targeted treatment for complex bladder pain patients. So without further ado, let's get started. We all have this patient that is entering your outpatient clinic, doctor, my bladder hurts. Often complaints that are going on for several years initiated after a simple urinary tract infection. It became progressively worse. She now wakes up during the night, um, and she feels that she's a little better after bladder emptying. However, no myalgia, no burning sensation, and luckily, no referred pain. But dyspareunia is sometimes present. She takes sometimes ibuprofen, which gives relief for a short period of time. Stool is normal with the occasional use of laxatives, and she's a non smoker. So, after thorough history taking, trying to understand where this patient is coming from, how long she has these complaints, and try to identify some red flags in her story, we move on to clinical investigation, where I add urine culture as well in primary as a primary investigation. So, here, after getting an informed consent, we perform a gentle clinical investigation, finding normal vaginal examination findings, a strong pelvic floor, no pain triggers, and no signs of infections. We asked her to fill in a bladder diary, which showed us a small bladder capacity during the day, no urgency, no incontinence. And then we have this discussion whether to perform a cystoscopy, whether to perform it in our outpatient clinic under local anesthesia, or if it's too painful, under general anesthesia. I think it's an essential criteria in this patient population, first of all, to rule out other causes, like, for example, bladder pain or stone disease. However, it is key in identifying one specific subtype of bladder pain syndrome, being the one with the Hunner lesions. What we do during cystoscopy, whether this is under local anesthesia or general anesthesia, we try to look for anatomical abnormalities of the bladder wall. It's not always there. There can be glomerulations, but sometimes we see Hunner lesions as well. If they're aberrant anatomy, we try to take biopsies if it's under general anesthesia, of course. And with the presence of inflammatory infiltration, mastocytosis, or fibrosis, we subdivide this group of patients into the classical type 3C bladder pain patients. I highlight this already now because this will have some clinical implications later on in this presentation. Looking at our guidelines, we see different definitions with different nuances. Our European guidelines, the EUA, describes primary bladder pain syndrome. It doesn't speak about interstitial cystitis, and it is the occurrence of persistent or recurrent pain perceived in the urinary bladder region, accompanied by at least one symptom, such as pain worsening with bladder filling and daytime and/or nighttime urinary frequency. There is no proven infection or other obvious local pathology. The ESIC, Society for Study of BPS, where there is next weekend their meeting in Milan, it described for them bladder pain syndrome describes actually all patients with a chronic pelvic pain, pressure, or discomfort perceived to be related to the urinary bladder, accompanied by at least one other urinary symptom. like, for example, persistent urgency or urinary frequency. On the other hand, we have SUFU, AUA, and the COA. They describe BPS as an unpleasant sensation, pain, pressure, or discomfort perceived to be related to the urinary bladder, pretty similar, and associated to LUTS for more than 6 weeks duration. So you see here that there is the addition of a certain time frame. However, heterogeneity in definition results in heterogeneity in patient population. And we know, or we do not know, in fact, the etiology of bladder pain syndrome is just not yet fully understood. However, we try to subdivide our patients in categories that we can more easily guide, more easily treat. And this is just a depiction of the different attempts that have been there in the past couple of years. For example, we have the 9 new expanded phenotypes according to Nickel, going from inflammatory BPS to primary storage symptoms. But he also, and this I think is very interesting, describes the 9th phenotype being the one with the flares. I think we should be prepared in every bladder pain patient for the occurrence of these flare-ups and discuss this beforehand to tackle them, to have a good strategy, and to reassure them that the presence of these flare-ups doesn't really mean a deterioration of the problem. More recently, we have the paper by Sandberg et al. In 2025, tailoring it down to 3 distinct phenotypes and also attaching some treatment recommendation. I do believe that phenotyping remains critical for both targeting treatment and outcome optimization. So let's dive into what I think are critical ingredients for success. I listed them here, going from non-pharmacological and behavioral treatment to oral medication, intravesical instillation, and becoming more invasive, some procedures, and finally major surgery. We abandoned the going from the first line into the 6th line model and try to really tailor down treatment, because it is not one size fits all, but it is individualized management. And it's not just one ingredient, but we try to combine it into a successful recipe. And this is most of the time a multimodal one. What are the goals of our treatment in bladder pain syndrome? It is maximizing symptom control and increasing quality of life of our patients while avoiding adverse events. We have to be honest, recognizing that there is no curative treatment, and set realistic expectations from the beginning on. And this creates an environment where shared decision making will be in the center of it. It remains individualized. There are a lot of algorithms that have been published, but there is no set algorithm. It will be trial and error, and you have to quit it if it doesn't work. Try to establish the phenotypes. I will go more into the detail on that in the next couple of slides. So let's start with ingredient number 1, behavioral treatment and non-pharma treatment. This is an essential ingredient in every phenotype that you encounter, in every patient that will sit in front of you. It's the base of your recipe. It starts with patient education, education on bladder pain, on the bladder pain syndrome, but also on pain itself. You have to try to explain these patients that pain is not always a dangerous symptom, but sometimes just a protective mechanism that became overly productive, like an overprotective mother trying to prevent harm for her child by just overprotecting her child, creating harm. By increasing knowledge on pain-related biology, this will finally result in a decrease in catastrophizing of the situation and even reduction in pain and disability. This has to start early on. Already in the acute setting, do not wait for it to become chronic pain. We like to focus as well on self-care practice. For us urologists, easy, the first one or the first 2, hydration optimization. Try to explain them that hydration is key, but to spread the fluids intake during the day and try to dilute the urine to decrease the irritative symptoms. Bladder training can be taught as well, with or without the help of a physiotherapist. I think stress management and coping with pain remains essential as well. And finally, we can advise or give them some dietary advice. We know that there are some bothersome food items and beverages, like, for example, citrus, spicy food, hot peppers, sauerkraut, but also coffee, tea, carbonated drinks, alcohol, that might induce flare ups or increase their pain sensation or bladder pain. This will be then an elimination diet and reintroduction diet, while with eliminating all the bothersome food items. And when you get into a stable period for a certain amount of time, try to reintroduce some of the food items to see whether this will cause a flare up again. Finally, we have the pelvic floor physical therapy, which is the only treatment that gets a grade A recommendation by the AUA guidelines. This is essential. It should target on finding the pain points and pelvic floor muscle tenderness, try to release the trigger points and go for myofascial relaxation. It should be stated when you send them for physiotherapy to avoid Kegel exercises and just strengthening exercises alone, as this can increase the pain sensation or the flare-ups in our patient, in this specific patient group. This one is one RCT by Fitzgerald, highlighting the additional benefit of physiotherapy, focusing on myofascial relaxation compared to just a general physiotherapy session, where you can see that up to 60% of the patients going through myofascial relaxation treatment by a certified physiotherapist have a great response. What do the guidelines say? EAU really focuses on trying to, try to subtype your patient in front of you and go for a phenotype-oriented treatment. And always consider offering this in a multimodal fashion, including behavioral, physical, and psychological techniques alongside with your medical treatment. This is essential. Dietary advice has a weak recommendation. AOA is pretty similar, focusing a bit more on patient education, self-care, and stress management is highlighted as well, and they give a grade A recommendation for the pelvic floor physiotherapy. Let's switch here. Okay. So moving on to ingredient number 2, our oral medication list. And so I created a grocery list with some items that are expired: prostaglandins, L-arginine, duloxetine, long-term antibiotics, and corticosteroids. They are not recommended in the treatment of bladder pain syndrome. So I will not go into detail. I just want to highlight for corticosteroids, I know they will induce a short improvement of their pain, but the long-term downsides of corticosteroids do not outweigh the benefits of it. So forget about that. I will talk with you about the antihistamines, amitriptyline, more systemic treatment, antizane, polysulfate, and cyclosporin A. So what about the antihistamines? There is a belief that in some subgroup of patients, the mast cells and upregulation of inflammation is a key role in inducing interstitial cystitis or bladder pain syndrome. Old studies have been tested cimetidine, which is an H2 antihistaminica. There is one RCT of 36 patients comparing cimetidine 400 milligrams twice a day compared to placebo for a short period of time. And you can appreciate here their results in 3 months follow-up with a significant decrease in suprapubic pain and nocturia. Although they did some histological investigations as well, they didn't see any changes in the gag layer, which is the inner lining of the bladder, trying to protect the bladder from toxins, bacteria, and viruses, for example. There are often old studies, no new ones. So for now, the EAU does not recommend limited treatment in bladder pain syndrome. However, the AUA gives it a grade B strength of evidence and suggests it as an option in a subtype of patients where we suspect inflammation and allergy as one of the key drivers of the syndrome. Moving on to hydroxyzine, which is again an antihistaminic. It's a first generation histamine receptor agonist. It has been showing mixed results. We have one case series of 140 patients showing a 40 to 50% symptom reduction, which is not bad. However, an RCT of 121 patients comparing pentosane polysulfate with hydroxyzine did not render consistent results. EAU, I'm sorry, will recommend it with a weak recommendation, but and the AUA suggested with a strength of evidence grade C, so a little less than cimetidine, and again as an option in patients where the key driver is suspected to be inflammation. It can be discussed. Moving on to amitriptyline, which is a better known systemic treatment. It's an ultracyclic antidepressant and suggested in patients with a widespread pain syndrome. It should be noted that the adverse events are a bit more severe compared to the antihistaminics. You can see here two RCTs. We have one old one from 2004 comparing amitriptyline to placebo. And after 4 months, we see a significant reduction in pain intensity and urgency intensity. So both tackling the LUTS and the pain, and with more than 60% of patients that are good or excellent after 4 months. A more recent in 2010 published RCT compared a multimodal approach with behavioral treatment compared with placebo compared to a behavioral treatment with amitriptyline. This on the contrary, did not show a success of the addition of amitriptyline. However, if they could reach higher doses of 50 milligram and more, there was a trend in the amitriptyline group of more pain reduction. However, if you look at the subgroup of patients that could reach 50 milligrams and more, this is not even 50% of all the patients. So the adverse events of amitriptyline might prevent the success of these treatments. So if you want to go for amitriptyline, you should start really with a low dose, 10 milligram, and try to go up every 7 to 10 days and see if the treatment is supported well. If it's not, try to reduce the dose just to see whether it's a success treatment or not. Both EAU and AUA will recommend it with a strength of evidence grade B or 1B for the EAU. It's a strong recommendation, but you should take bad adherence into account and discuss the possible adverse events that might compromise quality of life. And remember, one of the goals of our treatment is just to improve the quality of life. Just keep that in mind. We have pentosane polysulfate, which is a molecule which is highly studied in the treatment of bladder pain syndrome. I decided to show you here a Cochrane systematic review published in 2020, really summarizing the evidence for pentosane polysulfate. Unfortunately, we have to decide that there is actually a very low certainty of evidence of the success of pentosane polysulfate, both for improvement or cure of bladder pain improvement of pain score, and even LUTs. And this is appreciated here in the forest plot, summarizing all the results of the gathered articles. You see a very wide confidence interval and very close to the mean. So it's really uncertain. However, it is the only FDA-approved products for interstitial cystitis, but due to the unclear evidence, we should make some remarks, or we should explain this to our patients before embarking upon this treatment. I want to highlight, according to the AUA, it is recommended as an option in a subset of patients. And once you want to start it, you should ask for their ophthalmological history, because the treatment with pantosane polysulfate, there is an association with a unique retinal pigmentary maculopathy. So if you fear of an ophthalmological disease in your patient, send them for a checkup with their ophthalmologists, and they should be re-examined 6 months into treatment to prevent these irreversible complications of maculopathy. Finally, we have cyclosporin, which is kind of an immune modulator. This is more toxic. It has a narrow window of opportunity, or therapeutic window. So once started, you should guide your patient with regular blood tests to see that it reached the therapeutic threshold, but that does not supersede it and becomes nephrotoxic. It is suggested in a subgroup of patients with Vanner lesions that is refractory to hydrodescension with fulgurations. We have 3 prospective studies with a total of 165 patients. Treatment doses between 2 to 3 milligram per kilogram per day, and they looked at the results 6 months follow-up. They compared it to BPS treatment, and they saw a clear reduction in pain and an increase in quality of life. However, it remains a short-term follow-up and still a small number of patients. In the EU, it is not even mentioned, but the AUA, with a great C strength of evidence, does recommend it as a potential treatment in the Vanner lesion refractory to fulguration subtypes, but highlight the potential of serious adverse events and make sure that you can monitor your patients. Moving on to ingredient number 3, intravesical instillation. So you appreciate, so every ingredient that we add, it becomes a little bit more invasive. On the expired lists, there is BCG installations. I will not discuss them, but we have a lot of options for intravesical installation. Or they try to perform an anesthetic effect with lidocaine. We can go for the anti-inflammatory effect and muscle relaxant effects by DMSO. And then we have multiple molecules to try to replenish the gag layer. I already explained to you, this is the inner lining of the bladder wall, which is trying to protect our bladder from toxins, irritative substances, bacteria, and viruses. And you can really appreciate here in this biopsy of a patient with Vanner lesions, bladder pain syndrome, that this gag layer, which is normally the brown layer on top, is damaged, or in some places just entirely absent. So we hope with these intravesical installations to replenish the gag layer. I will not go into detail for every installation out there. I do know that there exists a lot of different cocktails as well, where they combine heparin with hyaluronic acid and lidocaine to improve the efficacy of the installation. It has its own dose, its own treatment scheme. Normally, we have it once a week for up to 4 to 6 weeks, and then we do a re-evaluation to start with maintenance once monthly. What do the guidelines say? There is some discrepancy between the EAU and the AUA guidelines, where DMSO is not recommended according to the EAU guidelines, but it is for the AUA with a strength of evidence grade C. However, the hyaluronic acid and chondroitin sulfate in for replenishing the gag layer is not recommended according to the AUA, I'm sorry. So check with your institute which cocktails you can offer, try them out and do an internal audit to see if these installations for some of your patients will be successful. If not, rethink it and adjust. Moving on to procedures, we have on the red list the high pressure hydrodistension. So don't go into your procedure without knowing how to perform this hydrodistension procedure. It should be short term and low pressure, and in combination with fulguration of Hunner lesions if present. Other options are onabotulinum toxin type A for refractory cases. And I have here mentioned neuromodulation as well with a question mark. I will go a little bit more into detail on that in a couple of slides. So let's start with hydrodistension. I think this is a well-known procedure in bladder pain syndrome. Hydrodistension on its own, however, is not recommended as a treatment option. It has limited effects. However, it is key for diagnostics. It will show us the maximum bladder capacity under anesthesia. Also, if there are repeat sessions, we can appreciate the evolution in bladder capacity. But it is of importance to see if there are anatomic abnormalities, glomerulation, and even more interesting, the Hunner lesions, which are these reddened zones of the bladder wall with the hypervascularity that goes or runs towards a central scar, as depicted here on the image. It's very pathognomonic for bladder pain syndrome type 3C. And if this is present, we can initiate the real treatment being fulguration, lasering of these lesions with or without a supplemental cortisone injection. Here you see a review recently published showing the good results of fulguration of Hunner lesion and hydrodistension combined with symptom relief up to, in some cases, up to almost 90%. You have symptom relief up to 50%, but it comes back in different studies. What you should mention to your patient beforehand that repeat sessions might be needed, and again, this will be individualized. Some patients will be good for a year, some you have to repeat already after 6 months. What is the use of botulinum toxin type A? We can add it to our treatment armamentarium alone or with the hydrodistension. Data, however, remains very heterogeneous, and there might maybe an opportunity in patient selection to see for certain types of bladder pain patients, Botox is the way to go. This forest plot really shows us the heterogeneity of the studies that has been done. You can see they compared it to BCG installation, hydrodistension alone, or intravesical installations, and the result of Botox goes both sides of the line with very wide confidence intervals. So we're not sure where to put it, but it seems to have some effect in certain patients. I do want to highlight the risk of intermittent catheterization. We do have to remember these are pain patients, and not every pain patient will be able to catheterize themselves. So take into account while making your recipe. What are the guidelines saying? EAU guidelines, they do highlight the fact that bladder distension alone is not a treatment, but just a diagnostic tool. They highlight the option of Botox with hydrodistension in the refractory cases, so when intravesical installation therapies have failed, and they do mention neuromodulation before more invasive intervention. And I think that the second part of the sentence is key. Neuromodulation, we have not a lot of data out there for the treatment of pain patients. We do have a lot of data on the treatment of overactive bladder. It is also reimbursed, at least in Belgium. But for pain, it is more difficult. If you embark upon a trial with neuromodulation, the thing I would suggest, though, is to do a prolonged trial period so that you avoid seeing them back during their honeymoon phase. They try something new. They really, really hope that it will work, and this will have a positive effect on their pain. But you have to objectify as much as possible in a prolonged testing phase. EAU guidelines, on the other hand, they provide a strength of evidence grade C for every type of procedure mentioned over here, and they highlight the fact that you should try to stratify. And so this brings me to ingredient number 5, which is actually our rarest ingredient, and an ingredient that I do not like to use a lot while creating my recipe with the patient. When we talk about major surgery, I do believe there are two distinct phenotypes that can sit before you. First of all, we have the patient with a fibrotic bladder, anatomical changes, small capacity, and Hunner lesions, and where we are almost certain that the bladder is the source of pain. On the other hand, we have the catastrophizing patient, a lot of pain, normal bladder, normal capacity, and also pain outside the pelvis. And we're not really sure if the bladder is the source of pain or is it extravesical. And before going further with this type of this group of patients, multidisciplinary evaluation is key. So major surgery should be suggested as a last resort. Patient selection is primal. And if you embark upon this journey, this should be with an experienced surgeon that is also willing to provide long-term follow-up and will be able to cope with potential serious adverse events and lifelong follow-up in your clinic. Once decided to move forward with the surgery, the next question is, what type of surgery will we do? Do we do a supratrigonal cystectomy, leaving the trigonum in place, and performing a bladder augmentation? This with this reasoning to keep it as physiological, as normal as possible, but we leave some part of the bladder behind, which might lead to some residual pain. We are not sure. On the other hand, do we need to offer all these patients a total or functional cystectomy with an ileochondrite, with giving them an incontinent stoma, which will most definitely impact their quality of life? This is a very difficult discussion you have to undertake with your patient, and preferably with a multidisciplinary team. In my opinion, predictors of failure before major surgery are listed here, and they include lower bladder capacity under anesthesia, the absence of Hunner lesions, lack of relief with local anesthetic bladder instillations, the presence of pelvic floor muscle tightness or tenderness, genital hyperesthesia, widespread pain syndrome, or a polysymptomatic or polysyndromatic presentation. And this is both in the EAU guidelines and AUA guidelines highlighted, where surgery really is the last resort, and only followed after multidisciplinary assessment. The AUA specifically stated that it can be suggested in selected patients with bladder-centric symptoms. So in the final couple of slides, I will use these ingredients which we discussed here to create some type of recipe. And for this recipe, we really have to dive a little bit deeper into the phenotype that we might encounter in our daily clinical practice. I listed this here in my cookbook. I decided to discuss with you the 3 main phenotypes, in my opinion, being the Hunner lesion phenotype with a lot of inflammation and immune upregulation. We have the low bladder capacity phenotype, where the symptoms stay bladder centric, but with not as much anatomical abnormalities. And then the widespread pain phenotypes, which are our most, if we are honest, our most difficult to treat patient population. It's often frustrating both for us as for the patient. So let's dive into our recipe. Let's see what we can come up with. So for the Hunner lesion phenotype, it's been described to be present in 5 to 57% of our pain patients. And just this broad prevalence highlights again how heterogeneous our patients are and how difficult it is to subcategorize them. However, in this phenotype, we have distinct visible inflammatory lesions present at cystoscopy. These are um, reddened mucosal areas with these vessels radiating towards a central scar. You know them. These are the Hunner lesions and pathognomonic 4 type 3C primary bladder pain syndrome, and nicely depicted here. Characteristics as well is after hydrodistension, these waterfall type of bleedings. Key driver in this phenotype is inflammation and immune upregulation. And the symptom profile, it seems to be that these patients are often a little bit older and that gender is equally divided between female and male. Whereas in bladder pain in general, it is more female patients compared to male patients, but not in this phenotype. Pain scores seem to be comparable to those with the absence of Hunner lesions, and they do get a smaller bladder capacity, which might evolve over time and becomes smaller and smaller. Treatment recipe is most definitely bladder centric. We focus, as I said, always on multidisciplinary treatment with education, with physiotherapy, with psychological support, but we can often offer directly hydrodistension with fulguration with or without these cortisone injections. So we don't have to start with systemic medical treatment first in this specific group of patients. In the refractory types, you can add to your recipe the cyclosporin A if they fail to respond to the fulguration. However, try to monitor these patients because of the severe adverse events that are possible with this immune modulator. Going into our next phenotype, being the low bladder capacity phenotype, present in more or less 1/3 of our bladder pain patients. The bladder capacity should be measured at low pressure, very important, and it's suggested to be measured at 60 to 80 centimeter water above the patients. There is no clear-cut definition on what a low bladder capacity is, but it's suggested to be below 400 mLs. Symptom patterns, they have often worse pain scores in the ICSI, ICP, PUF patient symptom scores, lower bladder capacity below 400, and they have the specific pain that increases with bladder filling. The treatment recipe can remain bladder directed. Apart from behavioral therapy, we can try anticholinergic or Betmiga Vibracron, which is now new on the market, but do your re-evaluation at specific time points. Botox injections might be a good one for this subtype of patients to increase the bladder capacity and relax the bladder. And here we might test neuromodulation, but yet again, for example, in Belgium, it is not yet reimbursed, and I would suggest to do a trial that is long enough to surpass the honeymoon phase after treatment induction. And then finally, our final phenotype, which is the widespread pain or nociceptive phenotype. These are the most difficult patients. We don't like to see them coming in our outpatient clinic. They often have co-occurring chronic overlapping pain conditions like fibromyalgia, irritable bowel conditions, chronic fatigue syndrome, and migraines. Patients with lengthy periods of pain and pain outside the pelvis. If you do a thorough medical history taking, because more often than not, psychological problems were there in the past or current psychological problems co-occur. The mechanism is a pain centralization with increased pain perception, catastrophizing, and the bladder is actually a bystander. So they're difficult to treat. Psychological guidance, coping, stress management are central and are essential, but we will choose here for systemic treatment more than local treatment. We do not want to medicalize them. We want to try to improve their quality of life. You have to set good expectations with these patients. And if we go for systemic treatment, this will be the type of amitriptyline, pregabalin, and if reimbursed are available, the pentazine polysulfate. So let me take you to my take-home messages or my conclusions. So it takes a village to treat these type of patients. As you can see here, it can involve a urologist, but think outside your own box and try to involve, if necessary, gastroenterology, gynecology, but also physiotherapy and psychology. I feel that the pain team or the pain clinic, but also first line, the general practitioner, are essential players at the football field. I think we all should be prepared for the flare-ups the patients will encounter. You have to discuss already strategies to tackle them and reassure them that a flare-up is not necessarily a deterioration of the entire problem, and optimize your recipe. We have a lot of ingredients out there. It will not work for every patient, and you have to be honest. If it doesn't work, just quit. Start with the less invasive treatment first. Try not to medicalize your patients, with the exception for the type 3C primary bladder pain syndrome, where you can go for invasive treatments first. Thank you so much for your attention. I'm very happy to see if there are any questions, and I'm happy to take them. Question from Jane, highlighting the fact that multidisciplinary approaches currently exist. She highlights several reasons, economical reasons for as a first one, but also time. And she asks how we can tackle this problem in the future. I think this is a very, very good question. I face this daily in my clinical practice, even in a university hospital, where time is an issue. It's difficult. What we do try to create is a multidisciplinary consult, where we discuss with some of my colleagues, being physiotherapists and pain doctors, to discuss the most difficult patients and try to see them back in an individual manner. So some of the patients will solely come to me, but I will get some advice from other specialists. But for this very difficult problem, I do not have a clear cut answer. I think patient organizations and governmental initiatives can be very helpful, highlighting the fact that even if we have a lot of chronic pain patients, this will impact our economics and absenteeism and presenteeism at work as well. So I think these initiatives should be stimulated as well. Next one. EMA only recommends one treatment for interstitial cystitis, oral BPS. This is not very helpful. How can we change this? Excellent example. In Belgium, oral BPS isn't even recommended or isn't even available anymore. So again, yet within your own hospital, I think you have to try and create a certain pathway flow chart with treatments that are available in your country, in your hospital, and discuss the available options with your patient. There is no treatment, there is no one treatment that will cure all the patients, and this is the difficult. This will be the difficult part. Be honest we do not treat to cure, but we treat to improve. And this is also being honest about the options that we have. If we had one cure for bladder pain patients, then the EMA would have recommended it. It would have been in all the guidelines and available and probably reimbursed. But this is just the reality that we do not have such a treatment. I'll just going through some other questions. Interesting question from Sadia. What is your view on the approach with ketamine uropathy? This is also a very important increasing problem worldwide, where pain is one of the drivers in the end of continued ketamine use. Although there is a distinct difference with our chronic bladder pain patients, with ketamine uropathy, we really have a toxic trigger. The molecules or the molecules derived from ketamine are excreted by our urinary system, and they will cause inflammation and fibrosis to our urinary system, and this will induce pain. So here we have already some guidelines that suggest specific treatment options if the pain persists, but there it's really easy. Again, ketamine has to be discontinued. So I wouldn't say that there is a lot of parallels. But for example, Botox and hydrodistension can help with ketamine uropathy, but the etiology is very, very different. What percentage is the last phenotype, widespread pain phenotype? It's very difficult to say as there is no clear definition on what widespread pain phenotypes are. It depends where the patient is followed. Is it with a urologist, a gastroenterologist, a gynecologist? And they are probably put into different boxes. But I would say in my opinion, it's around 40 to 50% of the patients that have this more widespread phenotype. Yes. The lidocaine installations, there is a question on the intravesical installations with lidocaine. How does this procedure looks like in practice, and how long should the patient keep the lidocaine into the bladder, and how many sessions are needed? Unfortunately, no set algorithms for this treatment as well. What we do, we provide the bladder with the concoction with lidocaine around 50 mLs, and we tell the patient to try to keep it up for 50 to 20 minutes. We do not do it regularly, and it can be done in a scheme once weekly or as a rescue treatment for flare-ups with patients that are known with flare-ups. You can try them. If it's working, you have an extra argument that the bladder is really the source of the pain. But there are some papers published that highlight certain treatment schemes. Yet again, no set scheme because the data isn't there. What is the common age group for primary bladder pain syndrome? Asks Andrew. All ages. In my pain clinic, I feel it's my peak is between 40 and 55. But again, I have patients with the age of 18 or younger. All right, I think I have them all answered. I'm not sure if there are still any questions coming.
I think that's probably it. I think we'll give people one more chance just to ask anything. It is what time are we on? We've got a couple of minutes left, but just a reminder again about the survey for everybody. Please fill that in. Also, if you're not interested in the accreditation, please fill it in anyway, because it's very helpful for us to get the feedback on these sessions. So I think nobody else is going to ask anything. I'd say thank you very much, Talita, for tonight's presentation. It's very kind of you to take
You're
the time
welcome.
to do it. Thank you to everybody for attending as ever. As I said, check out our website for the future sessions, and we'll hopefully see you back here again soon. I hope everybody has a great evening, and take care, everybody, and thank you very much. Good night.